harvested, like I said it before. But ligaments are very vital to the human body. We don't have a lot of ligaments just lying around in excess. So, as I said earlier, only 85% of people have the PL tendon. You have to understand that tendons, like though they are necessary for the human body, can be used at expense to help replace ligaments. That's why ligaments are replaced by tendons during surgeries. The docking technique. This is the first technique I want to talk about for the Tommy John surgery. So this gets kind of confusing, so I'm going to keep flipping back and forth between some pictures to help you guys understand. So 2 holes are drilled on the ulna. If you guys remember, the ulna is the pinky side, right, of the elbow or the arm. So 2 holes are drilled on the ulna, but only 1 drill is used. So if you guys can see here, there's 2 holes right here and here, but it's just 1 straight drill right through. Does that make sense to you guys? You guys understand that? Okay. So then, after 2 holes are drilled on the ulna, 3 holes are drilled on the end of the humerus, the upper arm, in a triangle fashion, but that's only 2 drills. So if we go back to that picture, you guys can see there's 1, 2, and a 3rd hole here. And 1 drill is put like this through here, and the other one comes out through here. So that's how we get the 3 holes. And this hole right here is a little bit bigger than the rest, but it needs to be because 2 tendons are coming through there. Does that make sense to everybody when I explain that? Yeah. Okay. So, the way that the surgeons are able to fix it is they take a tendon and it's looped through the ulna, and then both ends will pass through that first hole on the humerus that I said it's bigger than the other 5 because that's what they need to be. And then the tendon will be tied together at the opposite end of the humerus with sutures after the correct ligament tension is achieved. So that's a lot of words, so I'm going to walk you through it one more time on the picture. So here's the docking technique. We already went through the holes that were drilled. And then here's the tendon that we harvested from the body somewhere else, usually the PL tendon, from the near foot, whatever needs to be used. So they loop it through here, through the 2 holes in the ulna, and then it comes through and it comes to the bigger hole in the humerus, and then it is tied together with sutures. And at first I wasn't sure what sutures meant, but it's basically like some connective wire or whatever it is to hold tendons together, used in surgery quite a bit. So you can see it's connected back up here. Does everybody see that? Does that make sense to people? Okay. So that's how that's done. And then what kind of surprised me is I said that they connect it after they get the correct amount of tension in the elbow. So what kind of shocked me was that during surgery they have to figure out exactly what tension is supposed to be used for the correct ligament. So they have to understand exactly how loose or how tight the elbow has to be when you flex it or extend it or whatever it might be. So that means they have to make sure that it's tight enough or loose enough so the elbow will function properly as it would have if they had a healthy UCL. So that kind of shocked me that they were able to test it out and then get the right amount of tension with it. But as we move on, next is the figure of 8 technique. And it is a lot like the docking technique with some minor differences, but a lot different in effectiveness. And I'll get to that just after this. So there are 2 pairs of holes. That means like 2 drills, right? And 2 holes in the ulna, just like before, and then 3 holes in the humerus. So it's the exact same setup as the docking technique, right? So here's 2 drills and then 1 more drill right here in the ulna. But the only difference, if you guys can't see, is that the way the tendon is looped through. Okay, and I'm going to get to that in just a second here. So after the holes are made, the tendon is looped around in a figure of 8 fashion, and sutures fix the tendon together on itself. So, as you can see here, this makes like a figure of 8 looking type of pattern, or infinity sign, whatever you guys want to look at it as. But instead of the sutures being right here and connecting the tendon together, they're now down here connecting the tendon and then back on the tendon itself. Does everybody make sense? Does everybody see the difference between the docking technique? I'll show you one more time the differences. Docking technique, they come through the hole right here and the sutures are connected back here. And then the figure of 8 technique, it comes through the hole, makes a figure of 8, and then connected right here. That's just the main differences. Yes?
So do you need a certain tension for the figure 8 technique?
Yeah, so then the same process is used in making sure that the right amount of tension is for the elbow. So I looked up quite a bit which one is more commonly used and which one's more effective in surgery, the docking technique versus the figure of 8 technique. So the figure of 8 technique came first. Tommy John was a pitcher for the New York Yankees, and Frank Jobe was the first surgeon who created the Tommy John surgery. Tommy John was obviously named for the surgery. It's actually called the UCL surgery, but and the way he did this is Tommy John had what they usually call a dead arm. It was just referred to as a pitcher getting tired. I don't know if you guys know who Sandy Koufax is. Hopefully there are some baseball players in here that might know that name, but he's a Hall of Fame pitcher, had a great career, but he had to end it earlier than what he wanted to because they had what they call generic dead arm. And looking back on it, it very well could have been a blown or torn out UCL. So had he had Tommy John surgery with the results that we have today, he could have had a longer career and a more better career, yes. So the figure eight technique did come first, and then the docking technique, which is more effective, came afterwards. And I have some stats here that I looked up. The docking technique was associated with better outcomes, as there was a 76% rate of excellent results and an 8% rate of ulnar neuropathy in patients treated with the figure of eight technique, compared with 90% excellent results and a 3% rate of ulnar neuropathy in patients treated with the docking technique. I know like there were some big words in there that you guys didn't understand, like neuropathy, but I'm going to talk about that in just a second, because less complications in the arm after surgery is what it's getting to. Remember earlier in this presentation I spoke of the ulnar and median nerve? Well, the neuropathy, which I wanted to talk about, was in this picture. This nerve right here, which is the ulnar nerve, is around the back, okay? And then when they did the surgery, they would have to reroute the ulnar nerve, and that would cause some complications. So with the docking technique, they don't reroute it anymore in either the figure eight or the docking technique, but now in the docking technique, there's less chance of you having nerve damage later in life after getting the docking technique over the figure eight technique. So I'll come back to that picture, don't worry, I know you guys can look at that some more, but let me get through this first. So both are still widely used, the figure eight technique and the docking technique, for different reasons by different surgeons. But the less complications are found in the docking technique, and therefore is more effective than the figure eight technique, and is becoming more and more used as time goes on. Advancements in the surgery. This is probably one of the most interesting things for me personally. The docking technique, like I said, came after the figure eight technique, and is more effective, so therefore it is an advancement in my mind. And then splitting of the flexor muscles. Like I showed earlier, the flexor muscles again are on the inside part of your elbow, right here. And so to get to the bone, before there was advancements in the surgery, they would have to completely detach the flexor muscles from the bone, so that way they could access the joint. Nowadays, surgeons are able to split the muscles, the flexor muscles, and get right through to the joint, which causes less complications during surgery and less chance of getting hurt or something else happening during surgery. So, also the rerouting of the ulnar nerve. Like I spoke of before, obligatory rerouting of the ulnar nerve, which means basically like not needing to do it, used to be done all the time. And what happened was, as time went on, they were able to realize that the only time that you needed to reroute the ulnar nerve was if you had prior nerve damage or prior pain in the elbow that needed to be fixed. Otherwise, nowadays, they leave the ulnar nerve where it is, behind the elbow instead of in front when they wanted to reroute it. So that way it causes less nerve damage later in the road. Not right after surgery, but later in life there was complaints about nerve damage. So they were able to fix that up. So there are two major advancements in the surgery. And then probably, like I said before, here's the ulnar nerve, right? That used to be in the back of the elbow, which is now in, which they would try to reroute during surgery and put in front of the ligament. So rehab, this is probably where the most advancements have been in the past decade or so. And I said earlier that you usually get this surgery if you play baseball. So rehab has been a really big, important problem of this surgery, is being able to rehab it quickly and effectively for those baseball players that want to come back and be, a player for their team. So I just want to walk you guys through what rehab's like if you ever had to get this surgery. So after surgery, you're put in a splint for approximately 10 days or so, and it's almost completely immobilized, yet they do suggest that you do gentle hand grips, wrist and shoulder exercises while you're still in that splint, because you are getting surgery on your elbow, but it is surgery on your elbow, but like the whole arm gets affected. If one thing goes wrong, it's something else is going to have to